This is very different from just about every other medical conference you've been to, not only in the subject matter, but in the quality of your peers. You're going to find that you're going to have a lot of fun. So welcome. So now I don't feel bad about showing my first slide. Show this slide every time I speak. And it's a slide from an old Chinese medical text, and it says, superior doctors prevent the disease, mediocre doctors treat the disease before evident, and inferior doctors treat the full-blown disease. And as you can see, this is from a Chinese medical text from 2600 BC. So you can see how we have regressed in the way that we treat our patients over the last 5,000 years. But hopefully, with associations such as these and people such as you coming to these meetings, we can get back to what we really should be doing, which is keeping people healthy. Excuse me. Disclosures, I am the partner of Cenegenics Miami, and I am a member of the advisory board at Diadexis. So let's talk a little bit about heart disease and all of these things you all know, but I'm going to bring them up. It's the #1 killer of men and women. About 30% of the time, the first symptom is sudden death. About half the time, the first symptom is a heart attack or stroke. And 50% of heart attack victims have normal cholesterol levels. So the biggest point in this slide is that last line. It's that the degree of stenosis in an artery is not the culprit in a heart attack. And all the time, all the patients come to you, they go, are my arteries blocked? And I think by the end of this lecture, you're going to realize that's really not the major point. So more fun facts here. 68% of heart attacks occur in arteries that are less than 50% blocked. And only 14% of heart attacks occur in arteries that are more than 70% blocked. So the last line here is that it is important that you let your patients understand this. Because if they don't understand this, they're just going to keep asking you, are my arteries blocked? And you have to understand this. So what I tell my patients in order to, when they get it, I say, listen, what happens when somebody goes to the ER with a heart attack or stroke? They don't give them plaque busters. They give them blood thinners. Why? Because it's not the plaque that is causing the heart attack. It is the blood clot that is causing the heart attack or stroke. And this is the data for what I just said. It's actually fairly old. It's from the 90s. Valentin Fuster in New York published it. And there you can see how 68% of the patients are less than 50% blocked. But when you look at sudden cardiac death, it's even more impressive. 76% of the time, sudden cardiac death is caused by a ruptured plaque, not by a stenosed artery. So guys, it's not about the lipids. This is a slide from another talk I gave a year or so ago. And we all seem to focus on one test, two tests, cholesterol, this kind of stuff. But it's not about the lipids. Remember, you guys are doctors, okay? So look at the patient and treat the patient. Don't treat a whole bunch of numbers. Pay attention to the family history, the inflammatory and genetic markers, the risk factors, and the clustering of risk factors. The more risk factors you got, the more likely you are to develop the disease, especially smoking. Lifestyle modification, nutrition and exercise, hormone and metabolic optimization, stress management, and spirituality are all extremely important in managing your patient. So when you look at all these blood tests and all these fancy things, just keep in mind that you're treating a person, and you need to look at the whole person. We have all these new lab tests, which are out there. We've had NMR, we've got Berkeley Heart Labs, Cleveland Heart Labs, et cetera, et cetera. So we now have advanced lipid panels that do add to what we know about our lipids. We have genetic markers such as KIF6, ApoE, 9p21, and we have the inflammatory markers, which are very, very important. Fact, atherosclerosis is widely accepted. It is an inflammatory disease. It is not a stenotic disease. So, if it is documented that this is inflammatory, then you know what? Inflammatory markers must be pretty important, because this is going to be the way to treat the inflammatory disease. So what are the markers of inflammation? This is not by any stretch of the imagination meant to be all-inclusive. There's other markers, but these are very common. C-reactive protein, I'm sure just about every one of you use. Myeloperoxidase, F2 isoprostanes, which are more of a marker of lifestyle than they are they are a marker of inflammation, but tell you more about lifestyle. And then we have things like the PLAC test, which is why we are speaking here today. Microalbumin creatinine ratio is also good, but it's more for endothelial dysfunction. So why the PLAC test? Well, PLAC stands for lipoprotein-associated phospholipase A2, which is Lp-Pla2. commonly called PLAC because it's easy. It is the only one of these markers that has a sense of urgency, because it's the only one that tells you that something is going on today that may not have been going on the last time you saw that patient. It is also very easily treated, and it improves patient compliance. And why does it do that? And I found this in my practice. The reason is, I spend all the time telling the patient, listen, it's not about the plaque, it's about the blood clot. But boy, that word plaque really sticks in their head. And when they see my plaque is elevated, they start paying attention. And when they start paying attention, then you can tell them what it really means. So therefore, it improves the patient compliance. And also the test is very specific for vascular inflammation, as you're going to see a little bit down the road here. And the other thing is that serial results are very easily monitored. In other words, you can measure it today, you can treat it, and you can see your success the next time you draw the blood. It is now the only test approved by the FDA to assess the risk of heart attack and stroke. Elevated levels are associated with 5 times the risk of stroke and 2 times the risk of MI. And when you have an elevated plaque test with elevated CRP, these double. So it's very important when you have those 2 inflammatory markers together that you realize that something serious may be going on. As I said before, it's a very specific marker for vascular inflammation, and it plays a role in the inflammatory process leading to the formation of vulnerable plaques, and you're going to see that in detail in a couple of minutes. It's been linked to progressive and unstable atherogenesis, and elevated levels have always been a strong predictor of ischemic strokes and the risk of MI. Multiple peer-reviewed studies all over the world, there's a lot of literature all over the world on plaque, prove it to be independent and additive to other risk factors. And it measures the pathologic link of oxidized LDL, and I'm going to explain that to you in English in a few minutes. It's been documented as a risk indicator across different populations and levels of cholesterol. So it's independent of your race, population, and independent of the lipid levels. But yet, in all populations around the world, when the levels are low, we see that the individuals are very low risk. And it predicts risk independent, as I said before, of other biomarkers. That's the bibliography for that. It's very unique in that it's very specific for vascular inflammation. And this separates it from something like CRP, that just about anything elevates CRP. If you come in with a cold, your CRP could be high. If you have arthritis, if you don't feel good. But you cannot have an elevated plaque test without any significant event going on in your arteries. And you're going to see that the reason for this is that it's locally produced. And when it's locally produced, it only comes up when the artery is being affected.